5, 4, 3, 2, 1.
Oh, hi. Good afternoon, everyone. And good afternoon in some country in the East. Uh, this time is like our first webinar for my term of the president of APOA. Dr. Sholowit Jalalit from Thailand. This is a regular activity from our APOA hand and upper limb. The webinar. We regularly have an activity in the webinar about 3 to 4 times per year. And this is the first time that we change the pattern of our webinar. In the past, we have like a T Joy Origin together in the one webinar. But right now we try to change and make more specific in one joy that we change the pattern. So the first is the shoulder joy. Start with the shoulder joy. Thank you for Jonathan to set this that come to have a common expert opinion. It looks like that we try to have like interactive together audience. So it looks like that in the audience we turn to be our membership more and more and more. And we will have in charge to set the webinar in the next lovely about July. Please follow us and come to be our member and then have some fun activity together. So it looks like that I turn to Terence, right?
I'll go with it. Thank you, Shalawish. I'm Jonathan from the Philippines. I'm the president-elect for the Upper Limb Society. Good evening, everyone, and to our guest speakers, thank you for joining us. Thank you for joining us, to all the panelists as well. We have a commentator from Dubai, from Dr. Landro, and we have expert panelists from Turkey, Japan, Mexico, and India about this very interesting new and emerging topic in shoulder stabilization. So our speaker for tonight, thank you for joining us, Dr. Chi Hao Chu. He is our main man for tonight, and he has a background also in engineering and the chief of the sports medicine of Linkou Changung Memorial Hospital in Taiwan. He was trained under Alexander Lederman, and he is actually a very mean baseball player as well. So to speak further on DAS, please welcome Dr. Chi Hao Chu.
Oh, yeah. Okay. Let me share my slides. You guys,
Yes,
it's okay to see my slide now? Okay, cool. Okay. So, first of all, thanks for the invitation. For the APOA with quite some kinds of this technique even in the APOA meeting. So technique and try to tell the word that okay, why do I do DAS? DAS is a dynamic anterior stabilization with a long hip biceps. So when should we go to Taiwan? I work in Linkou Changung Memorial Hospital, which is the biggest private system in Taiwan. So my disclosure is that I have trained with the guy who first developed this technique. And when I was with him in 2018, we tried to organize and try to do some just a modification of this technique to the technique now. So I kind of at the first place to see it. I'm very honored to be trained by Dr. Alexander Lederman and also Joanna Spars, because you know, the French guys are very they are very knowledgeable guys. So they got a lot of different ideas, but they are very open to new techniques. So they also published a lot about the shoulder instability. So I'm mostly affected by these two gentlemen. Okay, so why do we do that? Because we know band car repair only fail about 30% in United States, especially in young guys. Okay, so the same situation is observed in Korea, almost 20% about failure rate, and also in South America. For the first 2 years, very good band car repairs still can provide some stability, but after 2 years, it's gonna fail, especially in contact overhead martial art player and young guys younger than 20 years old. Okay, so if you only do band car or upside repair without the remplissage, the 10-year survival rate will be less than 80% in states. Okay, like we're gonna to fail after 2 years. So if now we always add some additional treatment, most of the time the remplissage, or you can do like a free
Sorry,
bone
Joe.
block or whatever. You
The
can.
the slide isn't moving.
Yes. Oh, okay. Can you see it now?
We're still on the. It's not on the play mode yet.
On the very.
It's still on the
Okay.
first slide.
Oh, really? Okay. Let me check. Yes. Okay.
So while we're waiting for that, would like to inform our attendees to write their questions in the Q&A box, please.
Okay, let me share it again. Okay. Okay. Oh,
Yes.
yeah, now.
Good.
Okay. Oh, no, I think, wait a minute. I think it's the old version of the slide. Okay, guys, can you see the slide moving?
Yes, we're at the disclosure.
Yes.
Right.
Oh, now, okay.
Thank-
So yes, my okay. So maybe I start from the very first. So why do we do at 2 years after 2 years surgery in States, in Korea, and in South America? Okay, especially in like high demand contact overhead martial art players, and the young guys. Okay, so if now we do, well, I still do some soft tissue repair like Benka or upside repair, but I always plus some remplissage, because if you do not augment with some like remplissage or some bone graft, the 10-year survival rate will be less than 80%. Okay, so it's gonna fail after 2 years of success. Okay. So it's an interesting study from Yuan Bars in France. We know that France is the home of Lalage. So I don't really know they still do band car, but according to Yuan's study, band car failed after 2 years. For the first 2 years, it's okay, but after that, it reached the plateau, and it's not comparable to Latagé in the long run. So there's a debate of is the Bankart only repair dead? Okay, so there's still a lot of some surgeons they do Bankart only, and they claim that it will not affect the range of motion. But I think most of when you're facing a more demanding patient, you have to think something more than Bankart only. Okay, so for this case, it's easy because it's a 20-year-old high-demand fencing Olympic level player with huge gain of bone loss. So for me, it's a Latagé. Okay, but the problem is that if the guy is too huge, too big, with high body mass index, or the chest is too big, so sometimes it's very difficult for open Latagé to put your screws parallel to the joint line. So this is a study from JC published in HSM that in these guys, the alpha angle will be more than 25 degrees and will cause some disaster like overhang of the coracoid bone graft. And this is not my case, but operated in elsewhere in Taiwan. You can see the wound it's an open Latagé, but the wound is too lateral. So for him, it's very difficult to put the screw parallel to the joint line, which we like. Okay. So we know that Latagé is very strong, very useful, 99% successful rate in Lyon, but we still face a lot of complications. And most of the complications come from the bone, the graft, and the implant. Sometimes it's too long, it's too proud. Sometimes the implant just break. So there's a dilemma in Latagé that it's very useful, it's very powerful, but it's very dangerous. Okay. So in 2017, Dr. Philip Cullen and Alexander Lederman, they developed a technique. Actually, it's a modification of Latagé. With Latagé, you use Latagé or use free bone block, you need a bone over there. So most of the complications comes from the bone. So they just one time French as a biceps killer. So now they get the best use of the biceps. So I know that they have they're good friends, and they some discussion during some dinner, and they say why not they put the biceps into the glenoid just to mimic the Latagé, but it's kind of a soft tissue Latagé. Okay, so they published the article in Arthroscopy Technique in 2017. This is the original picture. Okay, and 2 years later, Dr. Lederman demonstrated his technique in NC shoulder course. By the time he used the 625 biotendon disc screw, okay, they tried to shuttle 2 centimeters of the bicep into the glenoid socket. Okay, and I was there, so when he finished the surgery, everyone was moved and give him a big applause. Okay. So this is the like the open view of the DAS. You can see it's just you make a split in the middle of the subscap, so it's just like Latagé, but with a bicep tendon. Okay, so that's why we do the DAS, because Bankart only fail after 2 years. So in some place, if you are not very anxious about the Latagé, you can try DAS, because for me it's safer and maybe easier. But when should we do DAS? Okay, so this is my case. It's a 70-year-old Olympic level boxer, first time dislocation. You can see there's a heel sex lesion, and there's not much glenoid bone loss, but we can see a Bankart lesion on our MR. So I'm not really doing first-time dislocators, but it's a very high level athlete. So I do the surgery. You can see inside the joint, the labor quality is not bad. Okay, so this is a heel sex. I do a remplissage with 1 anchor. Because the labor is good, I use a knotless anchor to achieve my Bankart plus remplissage. Okay, but this is a second case. almost the same, but it's a 18-year-old female. It's a semi-professional basketball player with 3 times of dislocation. He's semi-professional because we don't really have a professional female league for basketball. So she's very high demand. You can see on X-ray it's a huge Hill-Sachs lesion, MR also. But the labor quality is not comparable to the previous case with only 1-time dislocation. We know that the decrease of labor height was caused humeral instability. So all the soft tissue Bankart, we try to restore the bumper effect. But in this case, I'm not sure if I can do as good as the previous one. Okay. So sometimes we just go in and repair whatever we can do during the surgery. And if it's kind of difficult to evaluate the soft tissue quality during the surgery, before or during the surgery. So I try to search, and Professor Jin-Young Park from Korea, they published the article to teach us how to evaluate the labor and capsule quality during the surgery. Okay. The definition of poor labor quality is that you lack half of the labor thickness to the adjacent undamaged labor. And when you probe it, you'll feel some attenuation of the soft tissue. For the poor capsule quality, that you try to repair it, but sometimes it just cuts through when you tie it. So if the suture cuts through your soft tissue at more than 2 points, it's a poor capsule quality. So if you see this patient with multiple dislocation during the surgery, there's a risk to have a very poor tissue before you do the repair. Okay. So for this case, how do you feel like the quality of the labrum and the capsule? There's a Hill-Sachs, but for me, the quality of the labrum is not that good. So of course, before DAS was developed, I try to do the remplissage, and I try to repair as much capsule and labrum complex as possible. But can we predict the quality of the soft tissue before the surgery or during the surgery? Okay. So for bone, it's easy because we can do a CT to measure the bone defect. It's reproducible, and it's well established that if you have more than 20% of gainal bone loss, you should do a latage. Okay. But most of the time, we are not facing the big bone loss. Most of the time, there are subcritical bone loss between 10% to 20%. Okay. So in this cohort, I think JT mentioned that if there's a subcritical, they call it subcritical bone loss, about 13.5% of gainal bone loss. In this case, if you only do Bankart, you have a significant decrease in Worthy score. So you have to be very cautious in this subcritical bone loss patient, and which is the major population of recurrent anterior disability. Okay, and not only the gainal bone loss, but also the concavitivity is important regarding the shoulder instability. Okay, so Philip Moroder, they propose that the deeper socket may cause more instability. Okay, so let alone the gainal bone loss, we also have to take a look at the Hill-Sachs lesion. We are very familiar with Nobu's gainal tract theory, right? We know that on track, off track, and actually it's well developed algorithm in 2014 by Nobu, Iji, and Giacomo. Okay, we know that for the on track lesion, we can still do Bankart, but if it's off track lesion, we should do a remplissage. But it's developed in 2014, and today is 2026. It's already 12 years. So what do we learn in this 12 years? Okay. After the DAS was developed, so a lot of shoulder surgeons are very willing to test if it's a real or not. Okay, so Gus Mazzoca in Connecticut, so they proposed a biomechanical study, which I think is a very influential study, very first and very influential study. in 2021. Okay, so there's 24 native cadaverous shoulder. So they separate them into 3 groups. One is no bone loss, the other is 10% and 20% bone loss. And Gus just repair the Bankart and to see if the Bankart repair or the DAS repair outweigh the traditional Bankart repair. So we can see that if there's no granule bone loss or minimal granule bone loss, the DAS equals to the Bankart repair for the instability. Okay. But if there's about 10% of granule bone loss, which is very common in our clinical practice, DAS is stronger than Bankart. Okay. But you have to notice that if the granule bone loss is more than 20%, which is traditionally is an indication for LADA-J. If in this cohort, if you do the DAS, because we put the DAS at the edge of the granule, so you're gonna to push posterior or push back the head. So it's not relatively non-anatomical. So Gus, the conclusion is that in patients with more than 20% of granule bone loss, you should not do DAS because it's gonna to push the head posteriorly. Okay. Then it come more and more biomechanical study. It's a study from Baltimore. They use 475 Swiss block, which is very common, to fix the biceps. And you can see in their chronic instability model, the DAS is stronger than the Bankart repair only. Okay, but for subcritical bone loss, the LADA-J is the strongest. We can know that it increased the width of the granule, so it's rational. But in most of the time, DAS is better than the Bankart. Okay, this is another study from HSS. They compare the LADA-J, the DAS, and the Bankart repair. Okay, so in 0 degree neutral and 40 degrees of external rotation, we can see that the LADA-J and DAS plus Bankart is stronger than DAS alone and also the Bankart alone. So in 15% of granule bone loss, we should do you should do DAS plus Bankart if you don't want to do a LADA-J. Okay, so the indication of DAS for me is that you got the anterior granule humor instability when you had the associated sublesion, and you should have limited granule bone loss. Okay, so if the granule bone loss is more than 20%, you shouldn't do DAS. You should just go do the LADA-J. Okay, or sometimes when you are spontaneous rupture of the bicep, you're absent of the biceps, it's impossible for us to do a DAS. Okay, then how do we do the DAS? Okay, now there are 2 main strands of DAS. One is called onlay DAS. It's proposed by Clara and Ana from Portugal. Okay, so they put the O-suture anchor at the edge of the granule, and they use double pulley technique to fix the biceps and the cut of biceps, shuttle the biceps through the subscap split, and attach onto the granule. So it's like a labiaplasty to increase the bumper effect. Okay, so according to their report, all of their patients are very, very well at 1 year follow-up. Okay, so but for me it's kind of difficult in my hand. So excuse me. Okay, sorry, kids. Okay, so we have in our institute, we have our first onlay DAS in 2023. Okay, it looks quite nice. So it's my colleague, Dr. Xu. He got so it's a quite nice technique. But in my hand, I think it's quite difficult. Okay, because I was trained with Lederman. So our hospital have our first inlay DAS in 2022. To provide a sling and hammock effect. Okay. According to Philip Collin, the developer of the inlay DAS, the 3-year follow-up, 22 patients with arthroscopic DAS plus Bankart repair, and there are only two patients with failed DAS and have to be revised with a J. And you can see, according to the data, the range of motion is preserved. So they claim that the DAS procedure is a very good augmentation. DAS augmented with Bankar is a very good alternative compared to J or compared to previous surgery in anterior shoulder instability. Okay. And they, because we had some deeper talk with Philip, that the first two cases, because they are kind of in the learning curve, so they are not very confident with the fixation for the first several cases. So then those might be the poor indication or poor technique by the first time. So after they pass the learning curve, every case are very satisfied with their technique. Okay. So this is the inlay DAS without the rampage. But we know that in Bankar, rampage is Pittsburgh. Aberlin, this group, they developed a PIT score, Pittsburgh Instability Tool score. And they found that if you do the Bankar plus rampage, you can decrease 10 points of PIT score and make the shift the patient from extremely high risk to moderate risk. So I suggest now all the scopists to do the rampage along with Bankar or DAS plus Bankar to decrease the recurrent rate. Okay, it just take like 5 or 10 more minutes to do a rampage, and you can it's an easy technique, and some surgeon will claim that they lost some external rotation, but in my opinion, in my experience, that is not so obvious. Okay, so I try to do my DAS with rampage if it's visible heel sac lesion. So you can see the heel sac lesion with a slab tear. Okay, and we try to prepare the labrum first, okay, to expose the whole anterior glenoid. And then we shift our scope to the subacromial space to release the biceps like this, okay. Then we exteriorize the biceps outside the shoulder, and we can prepare the biceps. Okay. Then we do a drilling hole. I still use 625, so I will drill 6 millimeter drilling tunnel at the 4:30 o'clock of the right shoulder. Okay, so then we shuttle our prepared biceps through the subscap split, and we take out from the rotating interval. So the biotendinosis screw will insert it from the rotating interval while the biceps entering from the subscap split. Okay. So the final construct will be like this. Say there's some rescue suture from the biotendinosis screw, so you can still perform a Bankar with the same anchor, or you can use another anchor to repair the Bankar lesion. Okay, so most of my case we got only 4 stepping wound. Okay, if you are interested in the technique, you can check the arthroscopy technique. There's the detail and the cartoon picture are inside. There provide a video of that. Okay, so I try to evaluate my patient. It's a very short follow for only 1 year, and we try to include every patient with subcritical bone loss, and we do DAS plus rampage in this cohort, and evaluate the IC score, roll score, WOSI, and range of motion of them. Okay, 18 patients by the time, quite a young age, around 22. We follow more than 1 year, and the IC score is quite high because they are high demanding patient. It's 7.3. So according to Barlow, it's a J. But I think the benefit of DAS is, I think it's stronger than Bankar. So maybe we can decrease the amount of J. Okay, so glenoid defect is around 14%. Okay, after surgery, the range of motion did not change a lot. Okay, so we did did not really observe some loss of external rotation with DAS plus Rampisage. Okay, the SSV and row score and WOSI score all improve significantly. Okay, so for now there are no pulpite deformity and no cramping or other obvious complications for now. Okay, so go back to our second case, the 18-year-old female professional, semi-professional basketball player. Okay, I do a DAS. Okay, you can see after the fixing the DAS, there's still a possibility to repair the Bankart with the DAS. Okay, of course, I also do the Rampisage for this lady. So the final view looks like this. In my personal experience, because I started the DAS after 2023, so you can see I'm not the high volume surgeon for shoulder instability, but after the introduction, because we didn't have the tendinitis school before 2022, so after 2022, I almost do not do Bankart anymore. I try to do my DAS plus Bankart plus Rampisage. Okay, so I'm happy to know that actually this picture is from my friend and the panelist Alberto. He's very active in Instagram. So I'm happy. This is the guys who do DAS all over the world, and I'm happy to announce that Dr. Andrew Fan from Hong Kong, I think he did the very first DAS in Hong Kong, like two or 3 weeks ago. Okay, so but I still have some concern about the DAS. It's about the tunnel position, because we know that we should drill the tunnel for inlay DAS around 4:30 p.m. Okay, in right shoulder. So sometimes I have the tunnel at 3 and sometimes at 5. Okay, but they both doing well. But from time to time, we'll see that the tunnel position is too high. So I'm not sure if it's okay if we if we drill the tunnel too high. Okay, so Alberto and I and some friend, we're going to propose a study to see if the position of the bony tunnel in inlay does have some influence in our clinical outcomes. Okay. So for me now, if there's no granule bone loss, I still do Bankart plus Rampisage, but the chance is very limited because we now have a stronger or like a strong weapon in your hand. It says more than 20% of granule bone loss. I'll do open Latarjet because we don't have the scope instrument. Okay, but most of the time we are facing the subcritical granule bone loss. So for me, inlay DAS is more comfortable in my hand. Okay, so in conclusion, it's very difficult for me to evaluate the labor and capsule condition before the surgery and even during the surgery. So I try to persuade the patient or myself that we should do DAS in each case, which I used to do Bankart. So in our cohort, the inlay DAS plus Rampisage provides an alternative surgical treatment for anterior and inferior glenohumeral instability with subcritical granule bone loss and untracheal sac lesions. So there might be a paradigm shift toward DAS plus Rampisage in my previous Bankart patient. There's still some study we should do to see if the tunnel position affect the outcome or not. Thank you.
Thank you very much, Dr. Xu. It's a nice and elegant presentation first, and nice technique and elegant technique, I must admit. I don't do DAS, so it will be interesting because I will be the sort of devil advocate. But I would like to comment on this because it's probably there is a place for this dynamic anterior stabilization, knowing that, and you will tell me if what is your opinion about that, and we'll ask the panelists to comment, because the difference between Latarjet and DAS is not the sling effect, because I think it's the same sort of concept somewhere. And probably the people who developed that, they have this idea about how to do a sling effect with a different technique than Latarjet. But it's the fact that probably the DAS as a place for when you don't have so much bone loss or even no bone loss, but with capsular deficiency, which can be compensated by remplissage for some people. But you have a bipolar effect. So if you don't have a hip sacs extremely major, but you don't have bone loss on the glenoid rim, and you know that the capsule has some deficiency, you know that a Bankart will be probably won't be enough. So I know that your indications are increasing. Of course, it's always the same thing when you have a promoter of a technique, but do you think that it could be mostly an indication for capsular deficiency before to be an indication for a subcritical bone loss?
Hi, Philip. It's a question for me, right?
Yes. And I would be happy to have the comment of the panelists later on, but for you first.
Yeah, for me, the problem that I kind of to maybe abuse the indication for dust, because sometimes we try to repair the soft tissue, but we know that we should like have at least like a 3-point fixation. But for the first 2 point, like 530 or 430, you can still have a very good bite of the soft tissue. But at the third point fixation around higher part, it's sometimes very difficult. You just repaired, but you can see very thin tissue there. So I'm not sure if very successful, or maybe you will fail in after 2 years, like what the evidence has told us. So I am more confident with the sling and hammock effect after the inlay dust, because you can just probe it and you can see your head is just lying on the biceps, just like a hammock. So, and you can also repair the labrum if you want. So it kind of you feel it quite stronger, much stronger than the Bankart repair, like before the dust was developed. So I think Alberto has the same thought, right?
Just a second. So I'm supposed to be the moderator for this particular discussion. So my name is Dr. Prashant. I'm sorry, I think I missed introducing Professor Philip Landru. I consider also as my mentor and my very good friend. We used to work in Dubai together. He is one of the most leading shoulder and knee and sports physician, and a very well-known surgeon originating from French, but he has conquered the Middle East. When it comes to sports medicine, I think he's one of the top names to go for. We have learned a great deal in India because he keeps visiting for all the meetings and teaching us. So we are great to have Dr. Philip Landru as our chief commentator. And, I'm very interested in your comments, Professor Philip. And I would also like to introduce our panelists, and we really have like a global kind of people participating here, which is really nice to see, because we have different perspectives of what people say and what people do in their real life. First would be Dr. Karam Bilsel from Acıbadem University from the beautiful city of Istanbul. Next would be Dr. Yoshikazu Kida from Kyoto Prefectural University of Medicine. Then would be Dr. Alberto Alvarez from Mexico. And then my good friend, Dr. Amit Priyadarshini from Amrita Hospital in Delhi. So welcome all of you. And if now that, we just had a discussion between Dr. Philip and Dr. Joe, what I want to ask Dr. Philip on his comments is, if you go inside in a let's say someone who is a semi-pro athlete or a pro athlete, and we are expecting to have, and your plan is to do a bank card, because you just mentioned that you do not do DAS routinely, or don't prefer to do it. So if you do not find the quality of the labrum or the capsule to be so good, what is your next step? And these are the patients that they don't have bone loss. So how do you address it without doing a Latarjet, or do you jump to a Latarjet?
Question for me, Prashant.
Yes.
Yeah.
Yes.
Yeah, I think it's, of course, it's an interesting topic and discussion, because this DAS, this presentation on DAS, I think, let us think and ask some question about the real place of isolated Bankart procedure for anterior shoulder instability. And I'm talking about athlete. You know that I'm a fan of Latarjet. It's not because I'm French, but probably yes. And for traditionally, I would say long time ago, the decision was between Bankart and Latarjet. It was quite simple, and you know that. Then the remplissage came, and thank you, Shir, for this comment about the remplissage, because I see that you add the remplissage with your DAS, because I mean there is no reason to underestimate the effect of the heel sacks. Off track or on track, because we can discuss this, because I don't believe so much on the concept of on track, off track, because by definition, if there is dislocation, it means that somewhere the heel sacks become off track, and because we don't appreciate so much the anterior sliding of the subluxation of your head. So I really try to treat all the heel sacks that I have observed with my patients. So to answer to your question, if he's an athlete and he has anterior shoulder instability with the significant heel sacks, first of all, I will discuss with the patient, because I will give him the true percentage of recurrence. And now I understand that I change a little bit my position and my activity and the Latarjet for a long time, and the Bankart result, even if there is anterior and there is comparing
Recording in progress.
answer to your question. If there is no glenoid bone loss, I would try to avoid Latarjet, which is probably surprising in my mouth, if you know that I'm a fan of Latarjet, because the result of the Bankart and the remplissage are very good, even for this kind of athlete. And at least you later on, we know that it's good to, because revision of Latarjet is not so easy. So I would say that I do almost never isolated Bankart, because it's extremely rare to see to have Bankart without any heel sacks, and I think it's not a big deal to do the heel sacks is on track, because when we see the result and the effect of the external rotation, which is not as we could think affecting the rotation, I would go easily for a Bankart and remplissage, which is probably my main. So if there is a bone loss, and I can do a Latarjet, and I like you did, She has the Latarjet. Treat the bone deficiency and you treat the because we know that sex, but I think now we should treat all the anatomical lesion because we are facing in the majority of the case bipolar lesion. The treatment of anterior instability in between and
Recording
for
in
the future,
progress.
we never know. It's not the same age, so I will not. I will not use the biceps for anterior shoulder instability, but I understand that it's a good it's probably a good concept for some selected indication before the Latarjet, as you show us during this nice presentation.
Thank you so much for excellent comments. As a chief commentator, you can. What we would like to do is we would like to have all the panelists give their comments, and if they have any questions for Dr. Joe or Dr. Philip, we can have discussion. So let's start with Dr. Karam on what do you think your thoughts on DAS in your practice? What do you do? What is your selection process? And if you have any questions as well.
Thank you, Prashant. The great introduction, and thank you, Dr. Chiao, for your great presentation and your experience. Thank you, Philip, for having us. Like Philip, I don't have any experience with DAS, but when I think about the Bankart Plus surgery, especially in the subcritical bone loss, I always choose the remplissage as a Bankart Plus surgery routinely. I don't do isolated Bankart anymore, last maybe 6 to 7 years. I always add something more. But in one surgery 2 years ago, I started to do Bankart. I did my release, and during my release, the capsule and the labrum was ruptured with my release. Then the quality was not good, and I was thinking about what I can do. Then I do ASA procedure, arthroscopic subscapularis augmentation in this position. But maybe DAS can be a good option when you don't have a good quality labrum or capsule. DAS really give a good augmentation and good hammock effect on this site. And I have maybe I can use DAS in the slap tears, like slap type 5 tears, bad condition of the superior labrum. We can use DAS procedure. But is good technique. He put together the DAS and remplissage. Maybe it makes sense because you cannot do a good Bankart repair when you do the DAS. So to put together the DAS and remplissage makes sense to me. Thank you so much for your good technique and presentations. Thank you.
Thank you.
Thank you so much for that perspective. Can we, Dr. Yoshikazu from Japan, to please give his special comments on this particular topic, as well as if you have any questions further for the panelist or chief commentator.
Hi, Joe. Hi, everybody. Thank you for having me for panelist. Nice presentation, Joe.
We cannot hear you well. If you don't mind just speaking a little louder or coming closer to the speaker, please, sir.
Oh, can you hear me?
Yes.
Okay. Slap lesion. Your DAS technique is very useful because we have to maybe cutting biceps is good for the slap lesion. Baseball players in Japan, like Taiwan, and overhead athletes like in cricket players in India, volleyball players. What would you do, REM population?
Answer the question now. For pitchers, which is very demanding because pitchers pitchers are quite difficult cases. The players for positional players like infielder or outfielders, this kind of Bankart repair plus rump massage will succeed. But in the pitchers, it's very difficult. So in baseball players, actually, I haven't because now the baseball players are they are just in Taiwan. They play pitcher for pitchers. They just they only pitch at high school since high school, so they have low incidence to dislocate their shoulder. So for positional players, this DAS plus rump massage, but I'm not sure it's possible for pitchers because pitchers, they are kind of different animals. They need good external rotation, more external rotation than the normal guys, and the biceps may cause some stretch. And for good pitchers, they got a very flexible shoulder and they got loose anterior labrum. So if they even if the good pitcher dislocated his shoulder, it's very difficult for me to evaluate how much stability we should give them, because if you fix it too strong, they kind of lose the rotation and lose some speed. So I think that's the only the biggest problem in this patient. So I think there's of course for pitchers, we don't do Lalage for them, so they are very difficult to treat.
And one more, I agree. And one more question: How do you think about Hagel lesion? The indication of DAS for Hagel lesion.
Yeah, for me, I haven't done that. Yeah, but I think it's possible to do a DAS in Hagel lesion. Yeah, but I have no experience in that. But it's theoretically acceptable.
Thank you.
Yeah. Oh, maybe one. Sorry, sorry, question. One question for Yoshi that I know. We know that Dr. Sugaya, he didn't do DAS, but he treat the like very high demand athlete in Japan with the rotating interval closure. So I'm not sure if it's a mainstream in Japan or is the Bankart plus rump massage is the mainstream to treat the shoulder instability in Japan.
Yes, he does the Bankart rump massage and rotator interval closure for the high demand athletes. And if only baseball pitcher, he doesn't add RI closure.
We'll try to bring in Dr. Alberto Alvarez, 6 o'clock in the morning in Mexico. Thank you so much for joining us. And please kindly comment on what your experiences with DAS, what are people in Southern America doing, and how do you see this trend going up? And if you have any questions.
Yeah, thanks, sir. And thank you for the invitation. I think I'm gladly to join extremely at Saturday, 5 a.m. in the morning. It's a little bit challenging, but I appreciate the invitation. And so I think so I do DAS, and I basically do it as my main surgery for instability. So we have been pushing pretty hard along with Joe around the world with this technique. But I think we are still in this phase where we are building the knowledge and actually building the studies and bringing more and more scientific evidence because I think by the time we have enough to believe, but I think it's more a faith, it's like a faith issue, more like a evidence thing. So specifically my main objective with DAS is to build scientific evidence, because we think there must be limitations, there must be indications, there must be contraindications, and so on. So we just launched a follow-up for 78 patients around Latin America, and we're trying to understand first of all, we have many different techniques. We have different fixation methods. We have a different concepts. There's a bunch of people doing no remplissage to any instabilities. There's people doing remplissage to every instability, and so on. So we have a 2 years published, so I don't mind to speak about it. And we find really encouraging results, and we notice that the technique is really demanding, first of all. So it's not a simple technique. It's more like it requires a skillful surgeon. So that's going to be a limitation from the technique. Second one is we found that there is some stiffness around the shoulder, specifically in inlay fixations. So I was doing inlay fixation. So we know now that inlay fixation might be related to stiffness in external rotation that might not last forever. But at least now we know that, and clinically, it is important in the first couple of years. We have zero recurrence in 78 cases, but still, it's a short follow-up. So we're gonna follow this group of 78 patients in the years, and probably in 3 years we're gonna have a 5-year follow-up. We might have a number that can be compared to the literature. However, we have no high-power studies, and we are conducting a couple of studies. One with Joe Chu, and I always tell you Joe, so it's hard for me to say your full name. So I have a study with Joe, and we're trying to understand whether fixation on the glenoid, if it matters. But clinically, apparently, it doesn't matter. But it doesn't look well on the CT scan. We have some other factors that we're building. So I am biased for some reason because I have a heavy American education, but I did my shoulder training fellowships in Europe. So I try to mix both schools. But one of my measurements to know if this technique is actually going or growing or getting better or getting more into the field, it's the presence of this technique in the American market. So we have been hearing more and more this trend of this new technique getting involved into the US is fully Bankart remplissage for the last 20 years. Europe has been Latarjet mainly for the French school. So it's kind of funny to see how these techniques are merging somehow. And so again, I think we are in the time of where we are innovating in a technique. We are building the knowledge. We are not there yet to say this is the non plus ultra. This is the technique that is going to change the world. But it seems like the information that we have till today, 2026, it's actually supporting the technique and supporting the thought. So again, we will require a couple of years, and probably in 3 years from now, we will have better studies. And there's a lot of interest in the United States as well. And I think it's a great technique. I think you did great, Joe. I think we are refining those little details. It's going to be place the biceps inlay, or is it going to be onlay? Are we going to reconstruct the labrum or not? Or which cases are going to be the ones that are going to require augmentation or reconstruction or transfer of the long head of the biceps, etc. So I think this is a great topic, and I think this topic it's going to be still discussed in the next following 20 years. So I'm just happy to be in the time.
So thank you so much, Alberto. I think that's a very good perspective. The thing about shoulder surgery is every year we go for meetings, people are talking about new things, it just, you learn something new, and then you just get good at doing something, and then next thing you know that they have completely changed the algorithms, the percentages of bone losses and what to do. So it's very important that we keep on connecting on these meetings so that we can be ahead of the curve, and know. And it's also very good that we all can come together around the world to understand. Some people are really doing DAS and some people are really not doing DAS. Myself, I have not grown into DAS as of now. Probably I'm not finding that many people in my practice who actually are the candidates for that, which is probably a good news. But I'm happy to learn here. Bringing down Amit from New Delhi, from India. And after that, we have a couple of questions in the chat box. We have about 5 minutes to wrap this up. So Amit, what do you think about DAS?
So I have not yet bought it completely yet. I think I'm with Yoshikazu, Dr. Yoshikazu Karim. I agree with them. The right indication for me, I guess, would be I think when I don't find my good labrum or there is a slap tear. But rest of the cases, when do I do it? I don't see correct indications. So, which is what I would like to ask Dr. Shiha or Dr. Alberto. Are you doing this in less than 10% bone loss, or are you doing this strictly in subcritical bone loss? That's where it's been indicated. Because for me, if there is like less than 10% bone loss, I'm happy to do Bankart and Remplissage. Of course, I do add Remplissage in all my patients. And in subcritical bone loss, I'm towards the bony procedure like your Latarjet, your anterior bone block procedure. So I'm doing that. So when exactly do I do it? I think I'm pretty happy with the results which I do in my patients. So coming back to you both, when are you doing it with regards to glenoid bone loss, Dr. Shiha?
Oh, yes. Sometimes when we have less than 10% of glenoid bone loss, we are facing poor labral tissue because there are repeated dislocation. So it's very difficult for me to evaluate that on MR, on CT, or of course CT is not on CT arthrogram. So I always underestimate the fragility of the labrum. So now I'll say I'll do DAS, even if a very limited glenoid bone loss, because it's a soft tissue augmentation, stronger than the Bankart, in my opinion. And actually, we also repair the Bankart with the DAS. So I just do CT to see if the glenoid bone defect is too large to do DAS, and then we do the Latarjet. Otherwise, I'll try to do DAS plus Bankart plus Remplissage in subcritical bone loss, or even with very limited glenoid bone loss.
So you showed in your one of the slide that your DAS number is like much bigger than the Bankart repairs. So is that many percentage of patients you find lose capsulolabral tissue, not very good quality? Is that the number of patients, or is it like you're trying to do it?
Yeah, because I don't really do first-time dislocators. The case I shown is because it's very high demand, so it's kind of introduced from other places. So that's maybe my only case to do first-time dislocator. So in that case, we can see there's still strong tissue for me to repair. So I'm confident in that patient. But most of the time, they come with like a 3 or 5 or even 10 dislocations. So you can do an MR, you can see the labrum is there, but when you go in, it's very fragile. So then you have to decide to do a Latarjet, but they are not, and the patient are not, and even we are not prepared for Latarjet in this scenario. So I try to, even if we come in and if the labral quality is nice, they're fortunate to have a good quality for labrum. But I still do DAS and try to repair the labrum to cover the biceps around the edge of the glenoid. So, but before the DAS before the DAS was developed, I still do Bankart plus Remplissage, and I think Remplissage protect my Bankart repair. But now, since there's another tool in my hand, I try to maximize the tool, okay, which is a bicep. But I agree with Philip that maybe because they are young guys, 20, 30 something, maybe 30 years ago, 30 years after, they may need the bicep to augment with the cuff. So we don't know. We cannot, difficult for me to predict the things happen 30 years after. So for now, I just try to make sure that my instability surgery will not fail in 2 to 5 years.
Wonderful discussion. So I would like to take just two questions, because rest of the questions which I see are already been answered by the discussion we have. And the question is open to Joe as well as Dr. Philip, as well as all the panelists who want to jump in and kind of pitch in. That would be fantastic. So the primary burning question is about when you're doing a DAS, whether would you want to do an onlay or you want to do an inlay? And if you're doing an inlay, if there is an or the original biotenodesis screw.
Okay. For me, I still use 625 because the biceps, actually you have to trim the biceps into a smaller one because you need your biceps to go inside the bone tunnel to create a hammock and sling effect. So I still use 625, but for like very small lady, you can use 475 because you just use a regular sweep lock, but you have to trim the bicep even smaller. So I think the stability of the biceps is the key component of this surgery. So I try not to sacrifice too much for my biceps. And for onlay, the idea of onlay is it's like a capsuloplasty to create the stronger bumping effect. But I think in my hand it's quite difficult to see a lot of suture inside the very limited joint space. And also I'm trained with Dr. Lederman, so we developed the technique together. So that's why I still stick on inlay DAS.
Alberto, sorry.
Yeah, no problem.
Yeah.
Alberto, you did mention that you like onlay as compared to inlay, right? So why would you prefer it that way?
Well, the thing is, I evolved from one to the other one, and the reasoning behind this is that when I learned the technique with Alexander as well, so he was using a pretty big tenodesis screw, and for me, seeing at a 6.5 within the glenoid was quite shocking. You know, it's a big screw on a small place, and the glenoid is this pristine place where you don't want to see a bunch of stuff. So, anyways, I started with a technique with a tenodesis screw, but then I jump into the swivel of 425 inlay, which, as Joe mentioned, we have to trim the biceps into a 2 millimeter, 3 millimeter less than the actual size. But again, this was for me drilling a 5.5 on face perforation into the glenoid. So I was using a 475 swivel lock. But then the thing is again, when we start doing this CT study, it was like I don't like the way they look in the glenoid. It's more like a feeling about putting something into the glenoid. And there's a bunch of people somewhere else doing a DAS. Well, I have a couple of colleagues in Mexico City, and we're discussing this, and it was like, you know what? I once was doing a DAS, and I just had a 3.5 push lock, and I have to use it, and that's it on an on face. And then suddenly they understood that it was probably not forced to be within the bone, so they start doing only out of you know what happens in the OR. And so I start doing it as well because I believe in the strong fixation. I am biased in as well. I am an arthritic consultant, so we start building a little bit more of knowledge around the fixation. Then there's a bunch of studies about tenodesis and only fixation for tenodesis. You know, at the same time it was happening, the loop and tag technique for biceps tenodesis. The vector is different, so the pulling vector of the biceps is different, and we have pending a biomechanical study for that. But the thing is, we know that the knotless fixation is even good as well. I agree with Joe. I don't like the only fixation with suture anchors. You know, we have eight leaves of suture within the joint, and that's just a mess. It's hard to manage. Even if you knot the sutures and you remove 4 of the sutures, now you have 4. And again, I think it's a high demanding, only beautiful surgery, but it's not the one that I like to teach. So I now migrated to the only fixation with a push lock, and now we are developing some other fixation.
Thank you so much. So we'll just I see Dr. Karim's hand up, and also we'll take final comments from our chief commentator, Professor Philip Landru, after that.
Maybe one quick question to Xiao and Alberto. Is it possible to do it with endo-button fixation using the arthroscopic Latarjet guide? Are there some guys doing with this endo-button fixation, the DAS?
Yeah.
I don't know.
Can I
didn't
answer that? Can I answer that? Actually, someone from India, Dr. Ayyappan Nair, they published this technique in Arthroscopy Techniques using exactly what you are saying. So it's already published. And they have done it in a few cases, but I think they moved on to do an inlay DAS with 4.5 TNODC screw later on, because they just thought that drilling the guide and everything was getting a little cumbersome, like, but yes, that has been tried. They said that sometimes the biggest issue which they had was, number one, to get a proper trajectory to get the ACL guide through, number one. And number two is sometimes the button flipping can be a little tricky. It's not tibia, and tibia is completely different bone as compared to glenoid. Those are the reasons in which they said that they shifted from that to an inlay TNODC button. Anyone else, if you want to comment on that?
I would like to say something just before about this technique. There's already published in the JSCS by Jose Carlos Garcia from Brazil. Pretty nice series about using a button, and I think it's really interesting. However, for me, the objective, and I think for us, the objective is to make a replicable, easy to teach technique. And so getting into the button for me is just a little bit demanding. And again, I think it's just not the area to be playing with something that can go extremely wrong. If you're a high volume, well-trained surgeon, probably it's not a thing. But if someone tries to make this or emulate this technique for the first time, might be too much. And that would be just my point for education purposes.
All right, Dr. Philip Landru, as chief commentator, your final comments on this whole session, and just a request that if all of us who are available here, if you could switch on your camera, and we'll take a photo after Dr. Philip's comment, just for the records.
Thank you, President. Thank you, Xiao and Alberto, for your experience in this new technique. It's interesting. I would like just to do a comment and ask you a question about the concept, not on the technical point of view. It's interesting in the history of the comprehension of anterior shoulder instability pathology and treatment that with Burkhardt and De Beer paper about the importance of the bone lesion. Then we defined the critical bone loss, then the subcritical bone loss. I don't know if the next time it will be the subcritical bone loss. It's like if more we go, more, this is my impression, more we have the impression that it's important to treat the anatomical lesion, which seems obvious, but in surgery, sometimes we need some experience for that. And before the era of pure Bankart, as Alberto mentioned, everyone was doing only Bankart. Then we realized that we have to treat the bone deficiency on the glenoid, then on the bone deficiency on the humerus, and then the critical, subcritical. So based on this knowledge and this progression of compression and understanding of the anterior shoulder stability, I would like to ask you a question, because I know that among the promoter of the DAS, they propose this surgery for a subcritical. Everyone agree that critical bone loss, you have to restore the bone, either Latarjet, bone graft, or anything to rebuild the anatomy somewhere. And the subcritical seems to be something in between, you know, we can sometimes have a compromise. And the DAS seems for some people to be the solution. Do you think it makes sense to compensate with soft tissue augmentation a bone deficiency? I know what we need time and study to show if it is true or not, but what is your opinion and input on that?
For me, actually, for very high demand patient like our national team of judo, we use a lot of shoulder. Even for them without the huge gain bone loss or critical gain bone loss, I will do Lala J for them because they are very high demand. So I think the functional consideration is also an important part in our practice. But for like regular, not judo player, not wrestler, occasional sports guys, or even with volleyball players, I think this DAS plus Rumpy Sash is kind of alternative to Lala J. They will succeed in Lala J, of course. So, but sometimes it's just a technique in between the Lala J and the Bankart, and I think it cannot compensate for the bone loss. So, but sometimes we have to see the demand of the patient. They might be that if they are not that demanding, like national level players, maybe this relatively smaller procedure will work in this cohort. Thank you.
Hey, Philip, I would like to give an input in this. I think it's a great question. I think you hit the point because the only thing we're reasoning and innovating and discussing about new techniques about soft tissue fixation, it's because there's a place for it. I think there is a place, and the reason is we always when we talk about Bankart and something else for plus Bankart, meaning remplissage, meaning DAS, meaning capsule application, whatever. I think we're focusing, so always in the first slides, we say Bankart failure goes up to 35, 25, 15, 10, 45, and so on. And so the thing is, I guess there's a remaining 65, a remaining 75 that actually do well and they don't redislocate with a Bankart surgery. So there is, we know the answer, and the answer is yes, there is a place for soft tissue. So we don't know the answer for who is gonna fail and who's not gonna fail. So I think we're aiming about pushing the gap between understanding who's the patient that is gonna benefit or who's the patient who's gonna have a high failure of whatever soft tissue procedure. There's one of a Bowery rugby player, and I'm in my head is like, that is not an option for me. I have a rugby player and I'm going to go to Lala J, whatever the presentation they have, even if they have 0% bone loss.
Yeah, me too.
So again, I think there is room, and I think we're in the next 10 years, we will find those little indication. And when you see the variability among a lot of people, there's a valid variability for techniques. So there's going to be one guy with 10% that is going to require Lala J, and there's going to be a guy with 10% that is going to require DAS, and there's one with 10 that is going to do well with the Bankart, and there's a guy with a first-time dislocator, 15% defect that might do well conservative. So I think sometimes we focus on the technique, but again, I think it's a multifactorial thing. But I think it's a great question, and I think that will be the question that we have to answer.
Thank you so much for participating in this excellent meeting. I think we have learned a lot, and we have also raised new questions that DAS is really an upcoming, it is here to stay. It is not something which was introduced and it is going down the curve. It is really helping out a lot of surgeons, and this is something which I'm taking home that yes, probably DAS is something I should include in my armamentarium. I also understand there are technical aspects which are still being considered about how to fix it. We still don't know the long-term results. So we are still identifying, and hopefully next time when we meet in a webinar or in person, we will actually be knowing what to do in which patient, hopefully. So before I hand over to Cholavish for closing remarks, if you can take a photo of our group, whoever is there on the screen, if you can switch on your camera. And I would have the organizers to click a photo. And I was trained in Korea, so we have this thing of doing a heart. And if you could possibly try to do that with a smile. Cholavish,
Yeah,
come on, you're better than, yeah, perfect.
it show like you make a small cross in there. It's like a heart. Yeah.
All right, someone's taking it. We need to know if that.
Done.
Yeah.
Sure.
Thank you. Thank you so much.
All right, guys, thank you so much. All over to Cholavish.
Wow, it's very excellent about the discussion and interactive between our expert and speaker, and also with the question from the audience also. So I want to thank you all, and then I will make a closing ceremony for this webinar. Before that, we need to announce about the next webinar for us for APOA and upper limb in 18 July 2026. It's not for all of you, but it's elbow. So in the next item is like a pediatric elbow. So we will have the speaker from Campbell Wang and also Andy Asham and Ian Galloway from New Zealand. So the next is like a elbow, pediatric elbow. So hope to see you guys about it to be our member. And very thank you for all the speaker and commentator around the world that come to join our webinar. Thank you so much.
Thank you.
Thank you so much. See you guys around.
See you soon.
You.
Yep.